Universidad Católica Santiago de Guayaquil. Duration of adjuvant chemotherapy for stage 3 colon cancer. English Medical, name Adrian Lopez, Parallel D, Period A 2019, Facultad Ciencias Médicas. Introduction. Oxaliplatin with fluoropyrimidine has been a standard adjuvant chemotherapy in patients with stage 3 colon cancer. Three phase 3 trials convincingly showed that the addition of oxaliplatin improved disease-free survival with longer follow-up. These findings were extended to overall survival according a 6-month regimen of FOLFOX or CAPOX become the standard adjuvant therapy in stage 3 disease.
Six months of oxaliplatin-based chemotherapy is the standard adjuvant therapy in stage 3 colon cancer. Sensory-based neurotoxicity is a troublesome dose-limiting adverse effect of oxaliplatin that can affect a patient's quality of life. Since the neurotoxicity of oxaliplatin depends on the cumulative dose, could shorter adjuvant therapy be beneficial for patients if efficacy could be maintained? This pooled analysis of concurrent randomized Phase 3 trials evaluated non-inferiority in 12,834 patients randomized to 3 or 6 months of FOLFOX, a combination of oxaliplatin, fluorouracil, and leucovorin, or CAPOX, a combination of oxaliplatin and capecitabine. In the overall study population, non-inferiority was not confirmed, with a 3-year disease-free survival rate of 74.6% in patients randomized to 3 months of treatment and 75.5% in patients randomized to 6 months. The non-inferiority of 3 versus 6 months was seen for CAPOX, but 3 months of FOLFOX was inferior to 6 months. In exploratory subgroup analyses of combined regimens, 3 months was non-inferior to 6 months for T1 to 3N1 disease, and 6 months was superior to 3 months for T4 and N2 cancers. The authors conclude that non-inferiority was not confirmed for the overall study population, but that disease-free survival was strongly affected by treatment regimen and risk group. Full trial results are available at nejm.org.
Application in medicine. We use a modified intention to treat method to conduct the primary analysis, which include all the patients who had undergone randomization and had received at least 1 dose of a trial drug.
And another question that was just submitted. It's known that every chemotherapy helps only for a limited time. If I got chemo to prevent recurrence, does it mean I can't get the same chemo in case of recurrence? Okay, so that's a really good question. Right now, in our current treatment, usually for treatment of this preventative treatment, what we call adjuvant therapy of colon cancer, if it's stage 3 or high-risk stage 2, however that's determined, we would either use a single drug called 5-fluorouracil or a similar drug called capecitabine or Xeloda. So that's one kind of drug, 5-fluorouracil, and the other drug is called oxaliplatin. Most of the time we give people both 5-fluorouracil and oxaliplatin and for 6 months. And those drugs can be used again later if the cancer comes back. We like to try to use the strongest drugs that we have, though, at the time that we're trying to prevent recurrence because we want to cure as many people as possible. To use the drugs later on gives us a little bit less chance of being cured, so we like to use the most effective drugs as early as possible. But yes, if the cancer comes back afterwards, we would tend to use 5-fluorouracil again and possibly oxaliplatin again also.
Pros and cons. Pros. Being beneficial for patients to reduce the use of healthcare resources if efficacy were maintained. Cons. Rate of diarrhea, neutropenia, thrombocytopenia, nausea, mucosity fatigue. The hand-foot syndrome were also substantially lower with a shorter treatment duration.
stage 3 patients, almost everybody should be considered for systemic chemotherapy because there are adequate studies showing that single-agent fluoropyrimidine lengthens progression-free survival, and also combinations of oxaliplatin plus fluoropyrimidine lengthen progression-free survival compared to fluoropyrimidine alone. Therefore, unless there's a compelling contraindication or the patient refuses, I think everybody should be offered systemic therapy. The considerations in this case that are really driving us to strongly recommend it include the fact that they have a very high risk of recurrence based on the large number of lymph nodes involved. This patient has stage 3 disease, in fact stage 3C disease, the worst prognostic category in stage 3. However, if we took a different example, if they had no lymph nodes involved, for example, they would be stage 2. And stage 2 is an area where we actually have to spend quite a bit of time discussing with patients the pros and cons of taking systemic chemotherapy. The discussion I have with a patient that has stage 2 disease involves, first of all, trying to give them some sense of what their prognosis is with or without therapy. Here is where it's very critical to have information about microsatellite instability. A stage 2 patient that has microsatellite instability high tumor has such a good prognosis, and in fact they don't benefit from a fluoropyrimidine regimen, that we recommend they be observed only. But for a patient with microsatellite stable tumor, there are a number of ways to try to help them decide whether they want to take treatment. In a very simplistic discussion, one could quote the Quasar trial, where a group of patients that had mostly stage 2 disease were randomized to fluorouracil and leucovorin versus no systemic therapy after surgery. And there was about a 3.6% absolute survival benefit in that population who received the systemic 5-FU-based therapy. For other patients, they might want additional information about their tumor. Now, if they have a high-risk stage 2, for example, they presented with obstruction, or they had a perforation, they have T4, they have a poorly differentiated tumor, but are microsatellite stable, those individuals, we would typically recommend they consider systemic therapy because their risk of recurrence is quite a bit higher than it is for patients without those high-risk features. But for the more typical patient without any high-risk features who's microsatellite stable, who wants a little bit more information about their tumor, then one could perform an Oncotype DX, which would give them information about a recurrence score, which correlates with a risk of recurrence. For some individuals, if they had a sufficiently high risk of recurrence, that might drive them to consider systemic therapy. In patients with stage 2 disease who
Issues in Ecuador. Not in favor of a short-term regimen was seen for Capox as a rate of 0.95% CI, 0.50, 85 to 1.06, but not for FOLFOX. In exploratory analysis of the combined regimens among the patients with T1, T2, or T3 and N1 cancers, 3 months of therapy was not inferior for 2 to 6 months, with a 3 years rate of disease-free survival of 83% and 83.3% respectively. Among patients with cancers that were classified as T4 and 2 or above, the disease-free survival rate for a 6-month duration of therapy was superior to that for a 3-month duration for the combined treatments. Conclusion. Among patients with stage 3 colon cancer who receive adjuvant therapy with FOLFOX or Capox, an inferior of 3 months of therapy as compared with 6 months was not confirmed in the overall population. However, in patients treated with Capox, 3 months of therapy was effective at 6 months, particularly in the lower risk subgroup.
By giving adjuvant chemotherapy, we are converting the 50% of patients cured already with good quality surgery into a 60% of those patients being cured by surgery and the addition of postoperative chemotherapy. It's a very relevant number now. Adjuvant chemotherapy in stage 3 colon cancer is standard of care, is the use of a combination of 2 drugs, oxaliplatin and fluorouracil or oral fluoropyrimidines. So then both drugs are used, by using both drugs we are having a significant effect over 5-FU only, fluorouracil only, but the issue is that we will get by 11% of patients presenting with sensitive neurological toxicity, which is going to be severe. And for this reason, nowadays, we know that we can treat differently patients with low risk factors. So those patients having T3 and less than 4 lymph nodes involved in the surgical specimen, we can go only for 3 months of this combination of fluorouracil plus oxaliplatin. Doing 3 months of treatment is providing very similar results that 6 months of treatment. However, there is going to be a reduced rate of those severe neurological symptoms that may appear with the use of oxaliplatin. However, for high-risk patients, those presenting T4 tumors or 4 or more lymph nodes involved in the surgical specimen, the current recommendations is to treat with a combination of those two drugs for 6 months. So low risk factors, 3 months adjuvant chemotherapy, oxaliplatin based, high risk factors, 6 months of treatment is the recommended duration. We can use in this setting of stage 3 colon cancer oxaliplatin in combination with capecitabine, which is the most common oral fluoropyrimidine used in Western countries, or we can use continuous infusion 5-FU as in the FOLFOX schedule. The most important step in improving survival we achieved with adjuvant chemotherapy was with the addition of fluoropyrimidines. Oxaliplatin is adding on the top of that, but with more important and severe toxicity. So for patients over 70, we recommend to use fluoropyrimidine-based type of adjuvant chemotherapy. The issue of oxaliplatin could be for very healthy people over 70, discussed individually with them. But in general, we recommend a combination of this drug for people younger than 70, and after 70, we recommend single agent fluorouracil or fluoropyrimidines for adjuvant chemotherapy. I think it's very important that adjuvant chemotherapy is a must for stage 3 colon cancer patients, because we are going to provide a very strong and significant benefit on survival. We could consider diminishing or avoiding toxicity in this group of patients. For that, I would recommend reducing the duration of treatment for only 3 months, oxaliplatin-based combination in patients with low risk factors, T3 and one with less than 4 lymph nodes. However, for those having high risk factors, that means T4 or 4 or more lymph nodes, we should give chemotherapy in the conventional duration of 6 months.
Thank you.